Now it's 10:29, okay? And I would like to discuss the slides. Let's go. As you know, I'm working as a consultant with Allergan for many, many years. And today, we are decoding the surface aging trigger points. As you remember, when we worked together in the launch of this program, we mentioned that there are the surface and also the bone. Today, we're going to concentrate on the surface ones. A request, no recording, no photographs. What is important for you to know is this. If you go back to the beginning of 900, we see that life expectancy was 32 years old. And what happens when I compare to 2019 is has practically doubled. Not only are we live longer, but also we have changed our habits. Something that was, I would say, common and frequent today has completely changed. So we are exploring more and more our lives. So our habits have changed. And the question that I ask myself is this. As we are living longer lives and we are monitoring our health, because with new procedures that we are just fixing problems regarding the health so that we can continue running for longer and longer. The question that I ask you is this. Are we also monitoring our appearance? So it's always this balance, what we have inside and what we have outside as our envelope. So a question that I ask myself as somebody that's acting on the envelope, right? That has a lot of components that may also improve the patient inside. But let's talk about the outside. The question is, when should we start? Could we start? So aging is a sequence of events. We do not go to bed looking young, and on the following day we wake up looking old. There must be a sequence. So in this slide, the question is when we could start based on, it will vary from patient to patient, but if somebody asks me, Mauricio, is there an ideal age to start? Okay, so in my understanding is always before problems or issues, distractions become too complex. This is, this is what I understand as a philosophy, as an injector, right? Before. But it's very difficult to say, oh, is it 32, 35, is it 40, is it 21? It's very difficult. I have a rule, right? So there is a chronological age. If somebody looks younger, I would say that this person is genetically protected. Okay? But if somebody looks older for their age, for me, it's just like an alarming item. I must ask myself why somebody young presented an aged look. It makes me reflect. So what I want to discuss with you is always regarding an action that is named after the tipping point, okay? So there must be a tipping point. Once we end up by removing it, and time by time, we can have a change on our faces. Sooner or later, we will trigger a chain reaction, right? As I told, the tipping point. And let me discuss a little bit of tipping points. You have noticed that there are people that they age faster in their eyes, others age faster in the neck. Somebody is protected because he or she have a good chin. Everybody has different moments and different trigger points. Regardless where it started, my question is this. Could we avoid the trigger point in the chain of events? Is it possible? So imagine in this young 29-year-old lady that I just showed you. So there must be a reason why she looks tired and why she had a sad look or an angry look. So once I identify and I make the diagnosis, can I take it out as a trigger point? Now, if we do not act, we are going to have a snowball reaction. And this is something that for me, it's very, very clear. And that's why I get anxious when I want to treat somebody. So when I see somebody, I want to fix as much as I can as soon as possible. And why? There must be a sequence of events when problems get deeper, right? They start being double and then multiply until it gets an exponential expansion. And with this exponential expansion, one day we have the collapse. So is there a way to avoid this? This is all the time when I look at my patient, and even if the patient has little awareness about how they look, that's why that I take the consultation as the most efficient opportunity for me to open patients' mind, okay? So I use tools, mirror, different photos, different positions, so that they can end up by understanding better and better. Now, could we, this is another question. And making this intervention is creating the proper treatment planning. We have the tools in our hands. As you see, we have MD codes, we have MDAs for diagnosis, and we have here also MD Dyna codes. So I would like to introduce with you the Next Human program, MD codes, is structuring the future. So the idea is patients get stuck on minimal details. We know this. We know this all the time. Take a look. Remember the MDASA, hierarchy 1 to hierarchy 5. In hierarchy 5, this is where the patient may focus more, especially when they are in their own offices. They are trying to make up. They see with the magnifying glass. And then you see all the time, magnifying mirror, magnifying mirror. They see the tear trough. This is what they get stuck. And it's always something in the center of their face. Tear trough, glabella, nasolabial fold. It's interesting, this triangle, right? This region, this is the visible. Most of the time, because everywhere else is hidden for them. So I started assessing, and then take a look at the same patient now expanded in age 1, hierarchy 1. Here, I understand the full picture. I see definitely prominent tear trough, but I look at her and I start asking, how many realities does she present? Does she present only a tear trough? Or does she look tired? Does she look sad or angry? Or is there any degree of saggy appearance to her? So these are the realities that I try to understand time by time. And I, as an injector, I don't get stuck in the distraction, although it can be annoying for the patient. But I need to see a little bit beyond. I need to see beyond what the patient can see. Now let me give you an example of 3 different patients with different age. We have here 29, 47, and 45. All of them complaining about under eyes, dark circles, whatever they call, right? They don't know the medical name, right? But I would like to show you what I try to do myself. I try to expand their awareness and their vision, right? They see from a reality, which is a magnifying mirror in the bathroom when they are doing the makeup, and how to expand, how to make them see the full picture, right? And this is the full picture. My friends, this is where I struggle, and I know most of you struggle with me. Take a look. What's the diagnosis that 3 of them possess? They do possess the same, prominent tear trough. But take a look, the impact of the tear trough in these different patients. I would say that the patient that is 29, I would say that the impact of the tear trough would be very, very high. Then I go and I address the patient with 47, 45. Of course, if I treat her tear trough, they will look better. But would that make the impact so that they have the expected, I would say, external feedback. So, oh, you're looking good, you look refreshed, you look great, only by treating a small part of their faces. This is where I struggle, and I do believe you do as well. But let's hear what they have to say. Remember, patient wants, patient feels, and I'll present from these 3 cases that we're discussing now. So the patient number 1, she said tear trough, number 1. Number 2, malar, the cheek area. Number 3, nasolabial fold. Look, concentrated. Now, what she would like to achieve, she said, less tired, reality, and then she jumped to the dreams, contoured and attractive, which is, it's fair, because she does not present many realities. Although I can say that it's not that she looks angry, but she doesn't look too much approachable. But you see, it's fair, because she's 29 years old and she can have one reality and dreams. Then I go to patient number 2, which is the 47 years old. She complained about glabella lines, and then the jaw lines, and then lip lines. Look, for many years we are together and we are discussing this. The impact of the treatment, in her case of lip lines, the lines around the lips, although the patient may consider this very annoying. It's very annoying for her, I know, as it is for everybody. But the impact of treatment, and in this order, what I challenge me, I don't challenge the need, the wants. I don't challenge the wants. Maybe I challenge the sequence, okay? When the treatment of the lip line should come, okay? And then what she wants to achieve: less angry, less saggy, and more attractive. That's why I get stuck. I don't think if I treat her lip lines, I will make her look less angry. I won't make her look less saggy, and I won't make her look more attractive treating the lip lines, do you understand? So this is where I see the disconnection between patient wants and patient feels. And this is where I believe we can have our input as experts. Now let's go to patient number 3, 45 years old, nasolabial fold, and then she complained about her upper periorbital area, and then the chin. So this is, I will translate: refinement mid-face, refinement periorbital, and then contour lower face, okay? This is her want. What would she like to achieve? She was really aware. She only put the realities. She said, less tired, less saggy, and less angry. Fair. So I believe that once I have a patient before me that goes immediately to the realities, once they have the realities, it makes my life easier. And that's why you saw me today showing the consultation. I let them free in the reception filling form. I let them free when they look in the mirror. But when I show the photos of assessment and I say, okay, let us cut down and let us try to focus on 4 unfavorable messages, the realities. And then what I do is this: I say, any of these resonate with you, you can find only 1 or you can find 3, okay? So if they find 2 realities, because they only have 2 realities, then I show the dreams, then they can pick the dream. Initially, I let everything for them to opt from, which would make my life harder when I wanted to explain the aging trigger points, for example, right? So I do believe that working on realities should be the first step, and then I could tackle and I could address the dreams. So based on everything that we have seen together from year 1 to year 4, I would like to ask you to a tiny perception. There is an intriguing aspect that I think we should analyze and assess together. So take a look at this young lady. Beautiful, attractive, She presents a prominent tear trough and a tired look. And what is interesting, looking tired at 29 years old, there must be a reason. So this was the biggest change ever in my career when I understood it, and I was able to communicate this to patients. Whatever reality you present, regardless of age, there must be a reason, especially when you're younger. As you know, there is the law of action and reaction. I love to show this figure because maybe now it's become, with the aging trigger points, it will become clearer for you. When we hit a specific area, we have a rippling effect. This will compromise the others. So, meaning to us, I am here, there's something going on my face in a specific area, but it has consequences in another area. That's why I would like to introduce to you the concept that everything is connected, as you know, with the MD codes, and a beautiful concept named after to the areas. Why we treat one area and we can have a result in another one. Introducing the aging trigger points. We have to restore integrity to modulate tension and optimize function. So I look at this patient, take a look. The aging trigger points. We have to restore integrity to modulate tension and optimize function. So I look at this patient, take a look, the eye area. She presents key facial signs. Take a look. I would say the prominence of the tear trough and also the presence of eye bags. And then I position some points that we saw in the surface aging trigger points. And when I position this, it has a rippling effect. That's why when you look now and you see the surface aging trigger points, take a look how the lines are connected. So one aging trigger point connects into the other, and with this connection, it expands. I only put some of connections because it's much more you're gonna see after, but time and time, what I want to make clear for you and also after when I consult with the patient is to show that I cannot treat anymore isolated areas on the face. So take a look. There are 16 surface aging trigger points, and they are visible on the surface. They correspond to soft tissue deficits. Usually they have a genetic component, but also can be affected by environmental, like photo damage. We see that, and how we identify and make diagnosis out of it is about the key facial signs. Again, diagnosis, we use MDASA, multidimensional static scan assessment. So, interesting is that we see it. The surface aging trigger points are visible for the patient. Maybe not full because they don't pay attention, they don't know how they look in their profile and also tilting down and expressing. But it's more visible for them to understand. Then what we have, the bone ones. We have 8. And the bones is very, very interesting. They are located in the bone sutures. They impact structural stability. That's why when one of the bone aging trigger point is triggered, they will result an impact of instability, not only deep, but also in all layers. The cause is genetics. This is pure genetics, and we identify by palpation. Maybe now, my friends, we finally understand when I ask you to go towards CK1, I ask you to palpate the suture, right? Between the temporal and the zygomatic bone to identify the correct location of CK1. And by the way, this region of the zygomatic arch is the area of aging trigger point number 1. And let me get my scope, just a second. I'm not going to discuss a lot about the bone. So should I go to camera 3 now? Can you zoom in here? Camera 3, please. Close up. Okay, good. So, it's interesting that from embryology, right, we are one cell that becomes two cells, two, four, so on and so forth. And then we fuse in sutures. And these sutures, when you're fusing, can deliver instability that will cause on the surface. What I want to show you is there must be a reason why nature has created an interesting floating aspect. Take a look how the zygomatic arch was created, right? As a floating structure. So this structure that is not visible for people, but by talking so much about CK1, this region, we see that CK1 and mid face connects the upper with the lower face. So everything is generated along this region. And nature has created this for a typical purpose. And as we age, we know that there is a descent from upper to low, from lateral to medial. That's how gravity works. And the impact of changes on this area is what makes us never forget that the impact that we have on the surface will always have something underneath causing it. When we talk about asymmetries, this is even more important because we know that we are all asymmetric, right? So when you go to this tiny accident that we have, like this protruding anterior nasal spine, so a recessed area in the maxilla, so all of this will cause tremendous differentiation on the surface. So these points of the bone agent trigger points, they also have to be addressed, okay? They have to be addressed, and this is what I would like for you to understand. Nothing happens isolated, my friends, nothing. Everything is interconnected, and we use also MDASA to make the diagnosis. And take a look, the bone is always a framework. This, if we have a good structure, everything is gonna be better for the future of our patients. You notice that when somebody from genetics has a hypoplasic chin, right? Or hypoplasic mandible, we see what happens with the double chin and also the neck. If somebody does not have enough support, on the temporal area, or zygomatic, take a look. Somebody that presents no projection of the zygomatic arches, right? So they are narrow, take a look. Their face slides down, right? As it melts. Interesting. So the structure is very much responsible for what we see on the surface. That's why I think injectables have changed the world. So if you go back to the 80s, we only had like one syringe, and you would put on the lines, remember, it was even collagen at that time. We would treat only the nasolabial fold. But imagine now that more and more products with better techniques are coming, and then what you can see, we can restructure this framework. And not only the bone, but we can restructure the soft tissue, the fat pads, the subcutaneous, dermis, Take a look at the potentials now that we have in our hands. So I decided to bring these three beautiful young ladies from different ethnicities, and this is something very important that I want you to reflect again. If I show a photo of one of them, I believe in fractions of a second, I can ask you to make a diagnosis. Is it a man or a woman? Seconds. Is it young or old? Seconds. It's Asian or Caucasian? Seconds. But if I bring you the skull, and in fraction of seconds I show you and I hide, you are not going to be able to identify if this skull belongs to a man, a woman, Asian, Caucasian in fraction of seconds. Even, I would say, even if I let in your hands. That means if we are not familiar, if we have not studied enough, the differentiation of skulls can be very hard, right? But the surface is always very much differentiated, but not the bone. So the differences down to the bone are barely detectable. Of course that it may take some years to have bone reabsorption and changes in the angle that it exists, only for you to understand possibly when I'm start injecting the MD codes, then I go down to the bone, I can, yes, create the same quantity, the same location, no matter to whom. And the reason is simple. At the bone level, we are all the same. You see? So that's why I challenge all the time why we should adapt so much to treat the same messages. So when I have somebody looking tired, there must be inclusion criteria to make the diagnosis of a tired look. And the tired look is a combination of deficiencies down to the bone, fat pads, muscles, and skin. It's all together, right? So, what we see is only the surface. The patients even more. We have to put an effort to look deeper. Difference that I mentioned to you in the launching of this webinar of what's the visible aging and what's the hidden aging. Meaning to us, there must be something underneath. And I would like to show you this beautiful anatomical specimen that Dr. Kapoor for India prepared, okay? So you see, it gives us the accessibility, what the patient has, like, and then take a look the hidden aging. We have layers, so we go down to subcutaneous, then we go down to fat pads, and then we reach the bone. Our patients, my friends, they have no access, they have no understanding. That's why when I was showing my patient, right, the chart of the aging trigger points, the consultation, I was trying to educate her to try to make her understand about the iceberg. And the iceberg is an analogy that works very much in the consultation, very much. And that's why I love this sentence saying each person has their own iceberg. If you tell patients that what they see on the surface, there must be something underlying it, like an iceberg, we have a chance to expand the patient's opinion. Now, let us focus on the periorbital area. Now you have the full diagram with all the lines already interacting. Take a look. When I treat aging trigger points number 1, I make an effect in aging trigger points 2, 3, and 4, right? This is how I end up by making injectors understand that I cannot go only to number 7. The number 7, the aging trigger points, is infraorbital area. But take a look. There is not an isolated structure that's called infraorbital. It's related to everything. That means if you understand that we are something, right? That we have fat pads, we have bone, we have muscles, maybe as an injector, you're able to see that I cannot fix directly the issue. And we have been discussing this for many, many years. Now, if we are convinced, this is the moment when we try to educate our patients. If you're still not convinced, this is something that is going to be hard for you to expand patients' mind. So first work on you, then you work on your patient. But what I want you to assess is this. We are not isolated glabella lines. We are not isolated tear trough. We are not isolated prominent nasolabial folds. There must be something underneath. Now, let's consider the appropriate actions. As I showed you, for every aging trigger point, I have to make decisions as an expert. Should I monitor? Should I consider the treatment or should I put as potential for treatment? And remember, the assessment of monitor, consider, and treat should be based for age. You will also understand that when somebody is mature, right, most of the aging trigger points, they are already triggered. It's just like turning on and off the light. Imagine that everybody has potential areas to age, okay? And then it can be on and it can be out. What we know about aging is that all of the aging trigger points, sooner or later, they're going to be triggered. They're going to be turned on. And when we turn on an aging trigger point, it has a snowball effect. So this is the question that I ask myself all the time. Now let me make you expand your vision a little bit more for you. Take a look. I would like only for you to see what's going to come in the future, right? It's exciting, but take a look at this. Imagine that I have somebody at rest and smiling. I map them. I put the aging trigger points and I put all the lines together, and then I end up by doing this on animation. Take a look. I will take out the patient. There is a pattern. And this pattern can also be related to different patients. Imagine that I map a female, and then I map a male. And I create the aging trigger points, and I map them. I take them faces. I have a pattern. What we know, some of the aging trigger points on the surface, they will change position when we smile, and some of them when we age. This is from a theoretical, right? I'm still researching it. From maturity, they displace. We age from lateral to medial, up to down. So the pattern will also change. So if it changes for a female Caucasian, I would love to see if the same pattern happens with the female Asian. Guess what? Future for you to put in mind and start thinking about. Now, once I see and I map the aging trigger points, I go to MDAs. Remember, we have seen this together already. We have the key facial signs. She looks tired. Why? Is there a problem of the cheek, problem of the temples, eyebrows, tear trough? And then we create the equations. After the equations, we try to explain the how and the why for a patient. So I get the key facial signs, prominent nasolabial fold with saggy cheeks and volume loss. This is, and then I create the equations. How do I treat saggy cheeks? CK1, CK2, CK3, CK4. And then I go and I address the aging trigger points. So I use everything that we learned so far since year one in leaders, then visionary, then distinction. We put this together and we start understanding why we should use a structured approach to work on the aging trigger points. This is a table that I showed you. I'm not going to go into details now, but only for you to keep in mind. And then I have the table that I showed you. I'm not going to go into details now, but only for you to keep in mind. And then I have the possibilities of equations, and then I tailor to my patient. Look, her diagnosis is aging trigger point number 7, triggered. It's on. Then I have the potential equation. Then I tailor to my patient, right? So I tailor for my patient's need. So in her case, I could take out from the equation CK2. I kept T1 and I did TT1, TT2, TT3. So what I need to know to address correctly the aging trigger points, I have to know the code, which product performs the better with it, which layer I have to inject, should I use needles or cannulas, And then how should I deliver it? Should I fan? Should I bolus? And the volume. There must be the ideal thing, right? And this is what we study in year one. Now let's go back a little bit for anatomy very quickly, again from these images of Dr. Kapoor in England, in India. We see that these are the codes, my friends, that react down to the bone. Interesting. Take a look how many codes we have opportunity to fix the framework. So in this slide, we can see CK1, 2, and 3, and T1, TT1, TT2, TT3. But take a look at another one. When I get CK3, take a look, the icon now is not yellow anymore, it's bluish or green. And you see that I have CK3 with a cannula to work with Voluma, fanning. And if I go even more superficial, although under orbicularis oculi, I have CK3 fanning with Vollift to treat the SUF, suborbicularis oculi fat. Okay, now I have my patient to assess. And let me show you something, okay? First I will show this, only for me to start assessing her. You know, take a look, let's get, she complained about hollow eyes, remember, number 7, okay? Number 7 is here, right? Can you get me, my assistants, can you get me the alcohol gel for me to clean my hands? So, look, when I assess, in her case, right, let's see. I have you can put on my table now. You can have here, look. You see that in this case, right, I assess my patient and I have to make decisions. These are the aging trigger points, in her case, my 29-year-old patient that was with me, that were triggered. But let's focus on number 7. So in her number 7, I know, I will assess her, but maybe I will check how many of these codes would be important to work with, okay? So these are the tired look that you complain about, and this is what I have to work on. Sometimes I show the patient this. I show, you know, these are your trigger points that are triggered, and this is the treatment plan. So I have to have these codes to treat for you, and we are going to do it in multiple sessions. Okay? Only for you to see how it's working. Sometimes I even show my patient. Okay? So, it's very, very important that now that I have everything in my mind, I try to understand my patient assessment, right? Let's see. Let me get the... Look, this is very, very important for me to see. You see, the first thing that I want to show you is this. I have a frontal light here, right? And I have some side lights. Take a look. It's asymmetric, I'm sorry, but take a look, the presence of hollowness that she has in her left side. But this is, take a look at the difference when I look at her in her oblique view. And also when I tilt her down. Take a look. This is something that is very, very interesting for us to see. When I put her in orthostatic, no problems in tear trough, visible light. You see that here, I did on purpose shadows, okay? To see that when I have less reflection, I see the volume loss that she presents. And then I turn her and I put in the oblique view and I tilt her down to check how the structures moved from lateral to medial. Now let's work on the assessment here. As you may see, all the injections, I always start in the same way. I tilt down the patient and I ask him to look up. Then I mark the transition of the lower eyelid and the cheek. So this shows me, can you zoom in more or no? The more that you can zoom in, is the better for me. More, more, more. Let me see how much you can go. This is the max? Excellent. I would like to show you something very interesting. Everybody thinks that this dotted line is the placement of the bone, and it's not. Okay? So let me show you. The bone, no, always camera 3, please. Always camera 3. So this area of the inferior orbital rim usually is higher. So I need to, close your eyes please. I need to palpate, and then I will mark in white. Open your eyes, look up please. So this is the position of the bone. Okay? And here I have the transition with the lower eyelid and cheek. So what is aging? Look straight now. So aging is something very, very interesting for us. Okay, look up. I have the bone. Then I have the transition. Okay. And there is a distance here. In this distance between the bone and the transition, this is where we will have the direct approach for the tear trough. So we don't inject, we never inject intra-orbit. We have to inject below the bone, right? But with aging, there is a change in position. So the line between the lower eyelid and the cheek, it starts getting lower and lower. And we see the position of the lateral canthal area, okay? That over the time will show a displacement. What we know, there is a fixed area, close your eyes please, which is the medial canthal area, look. Okay? So, the area in blue doesn't change position. The area in white may change position. Now, let's observe her from here. I don't know if you notice, but she presents a slight bowing in her eyes. Take a look. Slight. The position of the lateral canthal area ideally should be 5 degrees higher than the medial. Okay? Now, if I have bowing, right, represented by a lateral scleral show, and I have to bring back the lateral canthal area to a higher position, right? I have to lift. I ask myself how I do it, right? Now, what we do, right? We come and we palpate the upper border of the zygomatic arch, the lower margin, feel the suture, and anchor in 3 points. This is a lifting factor because the cheek, zoom out a little bit, the cheek will have a tendency to grow from lateral, right, to medial. The brow, the same. Everything going and creating the jowling look. So, with the MD codes, we are trying to bring back to a better condition, right? So this is the area of the temple that I usually put the injection. So I try to counteract these two vectors, because this is so Mauricio, why don't you only do temples? It's not enough. We have to work on the vectors. Lateral, right? And I also need to give lower support. Look. So I check the patient in the oblique view, the presence of a good CK2 or not. In her case, she has a good CK2. So for her, when I'm gonna address aging trigger point number 7, I'm gonna work on CK1 that you are familiar already, T1 that you're familiar already, and then CK3. And after, I'm going to work with TT1, TT2, and TT3. So let's see the treatment planning here. Look, options for you, options. I have CK1, I have T1, I have CK3, then I have TT1, TT2, TT3. I tell you something very simple. I have to work with CK1, right? And CK1 usually I use 0.1 3 times. I have to work with CK1, right? And CK1 usually I use 0.1 3 times. Then I have T1 and CK. I have 0.7 left, right? Here is 0.7. And with this 0.7, I can either go to T1 or I go, or not and, I go to CK3. Sometimes I only need in a patient that is very, very young and they don't have any sadness and they don't have like a sadness in their eye. I can do CK1 with CK3 per side. It represents 2 syringes. So let's see this reality. Okay, now imagine somebody young, tear trough, volume loss, but no spiral show. Easy, you know? I do this, look. CK1, 0.1 in 3. Then I go to CK3. I put 0.7. I have 1 ml. I have 2 sides. It's a 2 ml treatment. It's a 2 ml treatment. It seems it's my fault that the patient needs 10 syringes. It's not my fault, understand? So this is a simple case. But the patient has the perfect eye position. But if the patient, my friends, they present sunken temple, right? And also upper eyelid hooding, I will need the T1 0.5. I multiply, I have 1 ml. I am already in syringe number 3. But let's suppose I don't know to do temples. I don't know, okay? Forget temples. But the patient needs TT1, TT2, TT3. So I have here 0.2, 0.2, 0.1. This equals 0.5 multiplied by 2 times. I have 1 ml. Okay, this is a 4 syringe for a given patient. So it's not that I inject a lot for each patient. It means that the patients present a specific key facial signs that I need to address. And if you go back to the solution of some of the aging trigger points, take a look. Number 7 can even be needed more. Imagine somebody that needs also T2 or different ways of injecting CK3. Do you understand the point? So this will vary for patient to patient. This varies for patient to patient. But when I treat, I respect the active number with the baseline. So can we go to the slides now? I'm going to show you now the treatment in a different patient where I'm going to comment on the video, okay? Okay? Now, take a look. Let's go back to my 29. They're both 29 years old, but you see that my live patient, her degree of the teardrop is much lower, the severity, than this one. She's in a better condition, so she would definitely need less volume. So what I try to do is this. I get specific problems from my patient, and I do a step-by-step approach to address the surface agent trigger points. So I check the treatment possibility. This is the full face. Then I grab one part of this face. And when I grab the part of this face, I start planning before acting. I don't take risks. I reduce the variables. So that's why you see me all the time planning beforehand. And this is my advice that I always tell you. If you want to deliver the best with minimal risk for your patients about like treating or forgetting or it was not sufficient, the treatment that you are discussing and also planning together, don't forget to check possibilities and also the budget involved. In this case, I show you two alternatives, then I will show what I did personally for her. There is alternative number one. I treat everything that the patient presents to try to deliver an optimal result, and in her case, that would include temples, right? I would say that her eyes, the bowing, lateral bowing, is better than my live assessment patient. But this is the planning if I'm gonna treat it, if I'm gonna treat all the codes that this patient would need to turn off the aging trigger point number 7. This is the ideal world. So there's a number. This number is 5 ml. And then you may decide with your patient in how many sessions you are going to do. What I do usually, I try to get to 4 syringes. I can take out the temples. Take a look. It's a possibility. Okay? Temples, 0.5. I only focus on CK1, CK3, and TT1, TT2, T3 comes down to 4. What I don't do, and you will never see me doing, is address directly the teardrop, because I don't believe that the teardrop is an isolated entity. I believe in interconnection. I believe that there is a problem in the cheek that communicates at the temple, that communicates to the bone, that communicates to the surface. I'm sure of this. So if I'm sure, I'm not going only to hit the tip of the iceberg. I'm going to try to treat as much as I can. Okay? So this would be an alternative for our patients when it comes to the treatment of the periorbital area. You know that in her case, for sure, I fixed the tempo as well. Okay? Now let's go to check the video, please. We're going to treat the aging trigger point. So take a look. Time by time, I ask the patient to tilt down, and I try to identify the marking. I mark, correct? Take a look how long the aging trigger point at the line, the junction is from the inferior lower eyelid margin. So I palpate the upper margin, the lower margin, Then I feel the suture. And when I feel the suture, I mark 3 anchoring points. I ask the patient to close her eyes. Then I clean, prime, I don't touch the needle, then I retract. So when I insert the needle, I aspirate and I inject 0.1 per point, okay? And this have to be done down to the bone. Let me talk to them now. Stop the video. Okay, my friends. The first thing that I'm gonna show you is I have to guarantee, right? I get my skull. This is what I go to camera 3 now. This is what I'm trying to identify. I try to identify the upper margin, the lower margin, right? And then I palpate the fusion. This is where CK1 central point is. And then I mark 5 millimeters and 5 anteriorly and 5 millimeters posterior. Can I have a syringe with volume with the needle, please? So what is this? These are the points that I have to address. But remember, thank you. Remember, my friends, look at, zoom out. So when I retract the skin, when I retract, the cheek will go laterally, right, upwards. But the areas that I want to put the needle in is in the projection of the bone, number 3. This is where I want to do. So that's why, my friends, when I expand my finger, the black dots changed position. Not on the bone, right? The projection of the bone is the same. And that's why I tell you, you have to inject slightly inferior and anteriorly. Let me do this. Okay? So I cannot draw, I'm so sorry. So I have here the zygomatic arch, okay, the fusion. So I put here the central, then I put 5 millimeters, 5 millimeters. This is bone, okay? So this is bone. And here, let's put is the surface, okay? When I retract, these original marks, they displace, correct? I retract posteriorly and laterally. So this one is here. This one, the second one, the central is here, and the other one is here. So down to the bone, when I inject, I'm targeting exactly these points. It continues to be the same point. But what I see on the skin is slightly inferior and anteriorly. Okay? This is what we see on the skin. Is it clear? So that's why it's mobilized. That's why I retract, because I'm targeting this. But when I move, as if I was tacking, the cheek higher. Let's go back. Now, this is the cleaning and addressing it. Let's see what happened immediately after. Take a look that this is why everything is interconnected. Take a look at the changes that she presents already in her eyebrows and in the tilting of her eyes. It seems something happened in the shape of her face. That's why CK1, I used to say that CK1 slims the face. It makes the face look slimmer. And observe the position of the eye area. So the position that I have on the cheek, because remember the cheek, camera 2, like peep. No, go back to the video. So remember, the cheek goes from up to down, right? I try to reposition back. This is why we mark the floating. Remember, nature has created floating bones for a purpose, to anchor the face, and I try to do the same with the empty coats. Then I work to identify the mid-pupillary line, and I'm marking her CK2. Her CK2 is an area, if I have the malar mound or if we have the malar sulcus, we cannot impact. Now I'm marking all the anterior cheek that is represented by CK3. So in her case, remember, she did not need CK2. CK2 is the red marker that I put on her face. If I am to address a patient without bone retrusion, I get a cannula now. So I clean the patient's skin, I enter, and I pinch very, very strong. And I pinch strong because I want to minimize the pain. I enter with the 23 gauge needle, I make a circular movement, then I have here volume. So, very importantly, I try to address the deep malar fat pad, start fanning. Observe my index finger, peep. You see, I'm protecting to avoid the product to go too high towards the orbit, and I want also to check the depth. It has to be deep at this level if I'm working with volume. So, I did 0.7 there, and let us see what happens. Full screen. Look, take a look at brows. Take a look at the changes in the shape. Also, take a look at her upper lip. If you remember, I'm injecting deep malar fat pad under all the upper lip elevators. This is going to be seen more and more in modulation program and MD Dyna next human. So take a look. The upper lip, her right upper lip, is already everting. Compare the upper lip on the right side and on the left. That's why everything is interconnected. Everything is interconnected. I do something here, I affect the brow, I affect the upper lip. It's naive to think I can only address the tear trough directly. Take a look at her upper lip. It's interesting to see. Take a look at her brows and also a natural position. Can you freeze? Freeze the video. Take a look when we freeze the video. You see how her peep. You see how her upper eyelid, her eyes are more open, and her zygomatic. It seems that she's smiling more towards my hand. Put the full screen now. Take a look. Why? I'm facilitating the muscle action. So I am restoring a previous condition for her. Next. Continue. Unfreeze. I'm just saying massage. Now this is the time where I address the temples. Okay, stop a little bit, I'm going to show them. So my friends, the temporal area, right? So can you show here? Look, this is bone, right? Now I try to palpate the fusion line between the temporal and, the frontal and the temporal bone, and here I have the upper lateral margin of the orbit. It's in this anterior and upper area that I try to inject T1. Okay? So you usually look from frontal, continue with camera 3, from frontal, and I retract and I position perpendicular. I'm gonna try, can I zoom in more? I aspirate, we see the bubble, and then I inject a bolus. In her case, it's gonna be 0.5. So take a look, it's a bolus of 0.5 in T1, as it was a bolus in CK1 3 times. I'm using the property of Voluma to anchor and lift. I try to lift the cheek and also lift the brow. These are the anchoring points. So I have 4 anchoring points. I like temples for this reason. Of course that there are some situations that we don't need to put temples, or you don't feel confident technically yet, but this is a part that we can address at a certain moment. Next. So, retract, then take a look. I position perpendicular, I aspirate, and I start injecting very slowly. If you see, I ask the patient to slightly open their mouth so that she can relax masseter, and when she relaxes masseter, she also relaxes temporalis, so she feels less discomfort. The patient can feel pressure, but it's not normal the patient to feel pain. Can you show me freeze? Freeze the video. Can you show myself then? What I try to see. I like to ask the patient to close her eyes, but sometimes they don't want to close their eyes. It's okay. But while I'm injecting, if I see the patient squinting, right? Something's not right. There should be no pain in the injection. If your hands are not stable, and if you rasp in the bone, the patient will feel pain. So this is why T1 we have to be with the hands very, very stable. Okay, this is very important for us. Let's go. So now I'm working on her temporal area. You can speed up until I show the result. Speed up a little bit the video. Okay, go back. Go back a little bit when she... go back when she sits up. Yes, that's it. So let's take out. Now you can run. Run the video, please. A benefit of T1, right, after CK1 is improve even more the eyebrow position. Take a look. Take a look higher now. I would like you to observe the eyebrow position. Take a look at her upper lip. And take a look at the shape of her face. Freeze. No, freeze with my fingers pointing. Go back 1 sec. Okay, run. That's it. Stop. My friends, observe. Beep. Observe. It's interesting. I only did CK1 with T1. What does this mean? Why everything is pulling up? First, she's young. Take a look her bone structure, optimal. Fat tissue, optimal. Fat compartment, optimal. Degree of sagness, minimal. So I do CK1 T1, everything lifts, right? So I tell you, for you, to test your ability with MD codes, focus on younger patients first to see if you can lift after CK1 and also if you can lift after T1. Because first we have to solve easier cases and then we go to more challenging ones. Continue. So I have the right position. We see, take a look, a change on her eyebrows, eye position, the cheek. She also looks slimmer. She looks less wide, narrow. Her upper lip looks a little bit more everted on her right hand side. Now you can speed up. I'm doing this because possibly she's having a little bit bleeding. That's why I am. Now the moment where I mark the SUF. The SUF here is the suborbicularis oculi fat. And I'm injecting under orbicularis oculi and above voluma. Okay? So cleaning. I get here normal speed. Put normal speed now. Now, this is the normal speed for vol lift in the SUF. The difference, I would say, is the same entry point, right, that I use for voluma and vol lift, but I'm now still not in the subcutaneous. I'm under orbicularis oculi, but I'm putting my finger all the time for two reasons. PEEP, protect the orbit first. I don't want anything to go. I get some adherences or attachments. And I want to see depth. That's what I'm aiming for, depth, you know. So I did 0.5. Full screen. And you see that I'm giving the inferior support. Freeze. Take a look something interesting. Take a look her position of her brow, upper eyelid. Also take a look at the position of the contraction of the pars palpebralis, the pretarsal area on her right hand side. It's relaxed now. Okay? Unfreeze. Continue. You see how her eyes became bigger, less squinting. This is what I'm showing now. Take a look. It's getting now with normal behavior. I ask her to smile. Take a look when she smiles, the changes that we have. And when she smiles, something interesting, her brows doesn't, her right brow does not come down. Okay? Now, take a look at the distance between the junction, between the treated and not treated side. So the eyes got bigger, the eyebrows got lifted. So everything now is being reshaped. So can you speed up now? So I'm doing this because possibly she's having a little bit bleeding. That's why I am now. So I ask her to do straight gaze. Take a look at the projection of the malar area. And now, you see, freeze, freeze. This is what I would like to show PEEP to you. You see that now her, you know that her, there is transitions. You see, there is like this, lower eyelid. Then I have a concavity. Then I have a convexity. Then I have another concavity. You see that her cheeks is full of waves, mountains and valleys, right? Ups and downs. So we try to make the surface more even by injecting multiple different planes. Continue. for the frontal, we don't see. And this is for me to check the power of the muscle on her right-hand side. Take a look. Her zygomatic is more pronounced on her right-hand side, which is youthfulness. Speed up. So now I'm going to the other side. I will speed up. So the same marking. So take a look. Cleaning, prime, and I retract and I inject where the black dot was, and I try to go in the direction of the bone, right? To really get in the right bone position. So after injecting 0.1, 0.1, 0.1, I have 0.7 left. And I'm gonna address now the deep malar fat pad with Voluma. So 1 ml per side so far. So, cleaning, pinch strongly to reduce the bleeding and the pain, 23 gauge needle, enter with the cannula, and take a look at my finger, peep. I'm using my finger here, always to protect. I want to protect as much as I can the orbital area. And I feel also the depth. I don't know if you notice the inclination of the cannula. Go full screen now. You see the cannula is almost bending. I'm under orbicularis, sorry, I'm under all the upper lip levators. When I go now with Volift, you will see after, you see that I went towards the surface. So touch the bone, aspirate. Remember, this is never the normal speed. It is speeded up so that we finish on time. And then we're going to address the SUF, the suborbicularis oculi fat. By injecting with Volift. Observe the cannula angle now. I enter with the cannula towards the surface. Look, different from what I did with Voluma. So I'm injecting 0.5 total under orbicularis oculi. So this would be 4 ml. She can go home, and after I can go with TT1, TT2, TT3. Okay? So this is a position, I usually work with micro aliquots. Get me Volbella with the cannula, please. So this is 020201. And both sides. I'm going to mark for you to know the correct position. Okay? So this is down to the bone, right? No, continue with the video. Continue with the video, then I show. We finished, right? Okay, put me together with the peep. I'm only showing the right position of the line. Okay, now let's go here. Can you go camera 3? So in red, this is the bone area, right? So in black, this is the line that is on the surface. Okay? Is it enough, or you can come here? Is it okay? Can you zoom in more, camera 3? The more as you can. This is the maximum. So I'll go even closer. Is it possible to zoom in here? Okay, so remember, the dotted line is the skin and the bone is upward. So when I enter with Volbella, in reality, I'm injecting micro droplets and the total is 0.2. Okay? In TT1, 0.2 in TT2, and 0.1 in TT3. So it's not a sausage. It's, you know, it's micro droplets, micro aliquots injected never intra-orbit, but 2 millimeters below the inferior orbital rim. Okay? Now, let's check the results. So, my friends, let's put full screen now. Look, patient that presented a tired look. This is her immediately after, but let's go to the close-up. Look, when you look and you assess, observe this size of the eye, how it opened, and the position of the upper periorbital area. Take a look how the pretarsal area in the upper eyelid has changed position, and so had the eyebrow. Now big smile. Let's see in detail. Take a look, something interesting. When she smiles, the same behavior happened. Her eye looked smaller before the treatment and looks wider after the treatment. Take a look. It seems that she's squinting less, right? We see the concavity of the tear trough improved and also the position of the brow. Take a look. So we see less skin excess. Now she's frowning, okay? But take a look when we have a close-up. You see that it's interesting, when she frowns, she increases the intra-orbit pressure, and then we see the eye bags bulging. But take a look at the size of the eye as well, and also the presence of the position of the brow. When she raises the brow before and after, we see less eye bags, right? But take a look, something happening interesting in her levator palpebra. You see that now it seems that she can open it better without recruiting so much the frontalis. If you see, take a look what happened in the frontalis lines. This is all to show to you that everything is interconnected. I have not injected anything in the forehead or anything in the frontal area. I have not injected her upper eyelid, zero, nothing. But take a look at the changes in behavior. Now, this is interesting. She's pouting, right? Baby cry. And when she's baby cry, you see before and after, she's baby cry normally. But take a look her glabella area. So when she's pouting, she's contracting corrugata, right? But take a look after. We see that there is a change everywhere, and we don't see as much protrusion of her eye bags anymore. So, this, my friends, peep, this is what I wanted to show. So I was injecting in one area, in another area, we are seeing changes. Let's go back to the appropriate action of this surface aging trigger point. Remember, we start by monitoring, then we consider, and then we have those for treat. Let's go back to her. All of this aging trigger points, in her case, only the periorbital area, I put to monitor number 3 and number 6, okay? Number 3 is the lateral canthal area, lateral orbit. And number 6 is the supraorbital, monitor. Consider temples. I always like to consider temples. Always, me always. When I put as treat, when it's very sunken, in her case, it's good too. And treat, number 1, number 7, and number 8. Okay? I see which one are connected with other. Okay? Now, we're starting point with at least 3 surface aging trigger points to treat and 1 to consider, 4, right? And I focus on number 1, 7, 8, and potential of number 2. So this was our mapping of her face in the before treatment. Everything that is in green is monitor. What is yellow is consider, and red potential to treat. And this was after. And then I ended up having changes. Everything that was either potential to treat or consider became monitor, right? So now I have the same patient that came before the treatment planning. Now she finishes her periorbital assessment with 6 surface aging trigger points already to be monitored. So depending on the age of the patient and the degree of severity, in her case, I have a review period, and it's going to be 1 year, right? In her case. If she has other aging trigger points in another area, this is a completely different perspective. But in her case, I can wait 1 year to reassess. So she is already in the monitor phase, right? So the big difference now that we introduce for our patients only during the consultation is the purpose why they should be treating the emotional attributes with the EMD codes. In the end, it's what we may deliver as a follow-up for them. And what I found in my practice that worked very well, imagine that this person, she comes and then she says, oh, I can even say, are you interested that I map your mother or your sister or your husband? So I started helping them to map. And everybody really wants to have a number, do you understand? And then it becomes for them a way to take care of them, do you understand? So they objectively know the whys, and we can give them the how. So never forget that by treating the aging trigger points, we will restore facial tensegrity. This tensegrity is a very interesting concept. And one day, a friend of mine, Zoda for South Africa, we discussed this in a dinner. She presented this word for me, and when I heard it, I was fascinated. So in the afternoon, I'm going to go deeper into this aspect. Okay? So we promise to finish neurotically on time. Just a second. Let me see. And guess what? We are 4 minutes to 12 to compensate a little bit of the delay that we had. Okay? So my friends, see you neurotically on time. Bye.